Hi, Brian Kaufman, the Chief Medical Officer at the CLL Society here in the last minutes of ASH 2018 in San Diego.
I'm Tate Shanafelt, a professor of hematology at Stanford University.
Tate Shanafelt, you presented some amazing, I think, treatment-changing research at the late-breaking abstract. There's only half a dozen late-breaking abstracts, so you really got to be an important paper to be presented there. So tell us about this study and why it was so important to patients to understand it.
Right, so we were able this morning to present the first report of the ECOG 1912 trial, which was a phase 3 study comparing standard treatment with fludarabine, cyclophosphamide, and rituximab or FCR, our current best treatment.
Phase 3 trials are the big trials that sometimes lead to registration or changing the way already approved drugs are used.
That's correct, that's correct. And so this trial was for CLL patients age 70 and younger, and we randomized the people who enrolled to either treatment with FCR, sort of our current gold standard treatment for young fit patients, or to ibrutinib and rituximab. And this was really the first trial to put ibrutinib-based therapy head-to-head with the historical best treatment.
So we'd seen that ibrutinib was superior to some older treatments like chlorambucil or ofatuzumab, but
Right.
this is using the most robust chemoimmunotherapy we had, and these were in frontline patients,
That's
right?
right,
Yeah.
previously untreated patients.
Yeah.
And so there were 529 patients who participated.
Big number.
Big
yeah.
number. 2 out of every 3 received the ibrutinib rituximab treatment. 1 out of 3 received the fludarabine-based treatment. And what we reported this morning was that at the very first interim analysis, which is now with about 34 months of average follow-up, the ibrutinib-based therapy is superior to the FCR, reduces the likelihood of progression by about 2/3.
Wow, so this is the progression-free survival we're talking about,
survival.
PFS, yeah.
That's right. And I think what was also striking is that in early follow-up, there's also a statistically significant advantage in overall survival for the ibrutinib-based therapy.
Wow, that seems unexpected to me so early on to see that.
It is a bit unexpected to see that difference early. I think the first inclination many of us had when we saw that result is whether that would be due to treatment-related toxic deaths in the FCR arm, infections or the like precipitated by the FCR. That's actually not what the data suggests. The most common cause of death in the patients who have passed on the FCR arm was CLL.
Wow.
And so, this is interesting and important initial result. The magnitude of that difference in both progression-free survival and overall survival was beyond the protocol-specified boundary of superiority for ibrutinib, and that boundary was set with input from all the 3 major cooperative groups in the United States, the National Cancer Institute and the U.S. Food and Drug Administration. So there was very stringent criteria put into the protocol before any patients were accrued, and the fact that both of those endpoints for progression and survival were superior for ibrutinib at the very first interim analysis, I think, is a really exciting advance for patients with CLL, and to a large extent moves us fully into the targeted therapy era for patients with CLL, and I think establishes ibrutinib-based therapy, especially when we consider this trial for younger patients and the companion alliance trial also in the North American Intergroup presented as a plenary at this meeting.
With Jennifer Wyack, and I interviewed Jennifer about that, yeah.
Yeah, so Dr.
That
Wyatt,
for the older patients, yeah.
Dr. Wyatt showing ibrutinib-based therapy
Yeah.
superior to bendamustine rituximab, and I think collectively the result of those 2 trials really establish ibrutinib-based therapy as the preferred initial approach for the majority of CLL patients.
So you also did some interesting subgroup. I want to come back to that, but you did some subgroup analysis, and the one that caught my eye was the mutated versus unmutated. Could you explain why that's an important difference for chemoimmunotherapy and maybe less important for the ibrutinib patients?
Right, so it's a great question. So with our traditional treatments, chemotherapy-based treatments, there was a difference in the effectiveness of FCR and other chemotherapy-based platforms based on whether patients were IGVH mutated or unmutated, where the mutated patients actually do better with the traditional treatments. With ibrutinib therapy, there's no difference. It works equally well between those two subgroups. The reason there has been great interest in that subgroup is that with FCR treatment, about 7 years after FCR, it appears that there is a group of about half the FCR-treated patients who are in a remission 7 years after they receive the FCR, and then just a straight line that they may be cured, they may have no further risk of relapse. And so obviously if we had a way to predict which 1 out of 2 patients were going to who are IGVH mutated who are going to be in that group, it might allow us to really deploy FCR in a very targeted way. But at present, we don't have the ability to predict that. But folks are very curious, will the ibrutinib be superior to FCR in the mutated group, knowing that that group has this subset that has a very favorable response? With current follow-up, when we look across all the subgroups, the ibrutinib-based therapy does appear to be better than FCR for all the subgroups. However, some of the subgroups are small in the number of patients they include, and the difference between the two different treatments is not currently significant. And that's the circumstance with the IGVH mutated patients at present. The fancy statistics that we do suggest that ibrutinib-based therapy reduces the likelihood of progression over FCR, but it's not currently statistically significant, sort of above, just slightly above the threshold. We do still know that in that subset, the ibrutinib therapy was less toxic overall, so there is a toxicity advantage independent of any effectiveness benefit. But I think we're all interested to see, as this data matures and as we have longer follow-up, particularly as we get out to those late time points, which are still probably 4 or 5 years from now, when we see that plateau or anticipated plateau in the FCR-treated patients, how will ibrutinib stack up there? I think that Dr. Bird presented some interesting results at this meeting that are from the initial phase 1b trial, looking at treatment-naive or untreated CLL patients who receive first-line ibrutinib. And with current follow-up at 7 years, 80% of those patients are still progression-free. There was data presented at the European Hematology Association by Dr. Berger in older patients from the RESONATE-2 trial who received first-line ibrutinib, also suggesting that the ibrutinib curve in front line is also going to be a very durable progression-free survival line. So I think that where we are today, we know that the FCR patients, a subset will do quite well at those late time points, but we know that many, if not a majority of the ibrutinib patients are going to be doing very well at that 7-year time point also. And so I think, based on what we currently know, the ultimate answer to that question, I think, is quite far off in the distant future. But certainly based on what we know now in all comers of excluding patients with the 17p, ibrutinib-based therapy looks to be highly effective in all comers, better than our previous therapies, less toxic than our traditional FCR therapy, and a very good first-line therapy option.
As a CLL patient, it's hard for me to imagine a circumstance. I can understand that there's a small segment of patients mutated with the proper predictive factors on their FISH analysis that might want to opt for 6 months and done. But I think for the vast majority of patients, and I might argue for all patients, it would seem that targeted therapies or a clinical trial of a combination of targeted therapies are going to be your best option at any stage of the disease, and now especially even in front line. I mean, is that off? Is that where you see things going?
Yeah, I think that's a very reasonable conclusion. I think right now, if you lined up 10 CLL experts from around the world and asked them this, focused question of, in the IGVH mutated subset of patients who are young enough and fit enough to tolerate FCR, with what we know now, what would you recommend? I think you would find, an even split. There are some who are very hesitant to move away from FCR with the currently available information, in part because we just have a long history with it.
Right.
We know its track record. We understand what that late curve looks like. And then I think many others will be in that group who would say that, ibrutinib certainly doesn't look inferior. It actually, at these early time points, is superior. For most patients, there's a suggestion that it may be superior at this early time point, even in the mutated. It's less toxic for all. And so I think they would lean toward that side of it. And that, personally, I kind of lean that side, but there is a body of evidence that can be used and be maybe interpreted two ways, and that's why I think there would be some differences of opinion. I think the other thing to note, however, is that as we get out to those later time points, there are also some fairly ominous toxicities of FCR that are also going to start showing up. Myelodysplasia being a particularly concerning one. And so even as we have this small subset, maybe half of the mutated patients, this subset who will maybe have a durable benefit, there also is another small group of patients who are going to have these really worst case scenario side effects of FCR that are very difficult to treat and will likely be the event that brings the end of life for those patients, is a late toxicity of FCR that we don't believe, based on current knowledge, is a toxicity associated with ibrutinib. So I think regardless, we're definitely in a new era. I think it is safe to say that ibrutinib-based therapy should be offered to every CLL patient in the frontline setting, and that for the subset of mutated patients, a discussion can be had with their physician. I think the main trade-off, as you said, is that FCR-based therapy is a 6 months of sort of vigorous intravenous treatments, but then you're off therapy and in observation for most patients, whereas ibrutinib involves that chronic daily administration of a pill, as long as you're tolerating it and it's controlling your CLL. And so there's a bit of a paradigm shift from a time-limited treatment to a chronic daily pill. And there may be some patients who that distinction is something that matters to them and may choose the chemotherapy for the ability to have that time-limited approach. But I think, as you said, my suspicion is that with a discussion with their physicians, patients can come to a good answer, and that many, if not most, will likely choose a ibrutinib-based strategy.
Any final thoughts you want to share with patients of what I think is a paradigm-shifting paper that you presented this morning?
I think maybe the only other, maybe indirect aspect of this that I would point out that I hope can be a source of encouragement to CLL patients is that I think the presentation at this meeting of the Alliance trial and the ECOG trial represent really the best of collaboration of CLL investigators from across the United States working together to ask complementary but different questions in trials to accrue to those trials more rapidly than was even projected. And that because of that, we're here presenting results that I think most people didn't think we would have for another several years. And we're bringing answers that are changing the landscape of treatment for patients more rapidly because of that collaboration across the cooperative groups. And I think we're continuing that. So this month, 2 new trials will activate and begin accruing patients. The ECOG trial is for patients 70 and under. The Alliance trial, again, for patients 70 and older. And again, designed collaboratively with Doctors Bird, Wyatch, Dr. Kay, myself, other members of ECOG, the Alliance, SWOG, looking at those to really ask complementary questions and also to provide trials that all patients in the United States would have a trial of relevance to them available that they can participate in, and hopefully let us continue to bring answers to patients more quickly.
Professor, thank you so much. I promised Dr. Wyack, and I'll promise this to you, if you give me the information on those trials, we'll put them up on our website. We'll link people to them so people can find a center that's doing them, because, you know, if we have a bias here at the CLL Society, it's towards clinical trials, and we want to see these trials accrue and answer these questions. Thanks so much for what you're doing.
Thanks, Brian. Really
Thanks.
appreciate it. Thank
Thank
you.
you.